From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, and welcome to our listeners from around the world. I'm Dr. Paul Bryson, the director of the Cleveland Clinic Voice Center and your web editor for JAMA Oto. And today, I'm delighted to be joined by Dr. Molly Huston, Associate Professor of Otolaryngology at WashU Medicine and Director of the Voice and Airway Center at WashU, as well as Dr. Will Strober, Resident Physician at WashU in their Otolaryngology training program. So welcome to the podcast.
Thanks for having us.
Thank you so much for having us.
Today, we wanted to highlight a study that you did on biofeedback versus respiratory retraining for inducible laryngeal obstruction. And it was a randomized trial. As we get started, could you tell the listener a little bit about what is inducible laryngeal obstruction? ILO, what is it?
Yeah, so inducible laryngeal obstruction, first of all, goes by a few different names, including paradoxical vocal fold motion, as well as vocal cord dysfunction. And it's a condition where the vocal cords adduct or come together during inspiration instead of abduct. And this can lead to episodic symptoms, including dyspnea and stridor. And it definitely remains very underdiagnosed, and it's been found to be quite a burden on the healthcare system overall.
And is this something where somebody will say, oh, you have asthma or you have exercise-induced asthma? And I would imagine there's a couple different pathways that these patients might find themselves in the otolaryngologist or subspecialty laryngology center.
Yes, definitely. I think the majority of patients are requiring at least a few years from symptom onset before they're finally diagnosed. And yes, very often masquerading as asthma.
I'd like to add also that this can be comorbid with asthma, and it's thought of as a modifiable trait. So along with other comorbid traits like acid reflux or mental health diagnoses, the thought being that improving these comorbid conditions will lead to better asthma outcomes, less hospitalization, less inhaler use, decreased steroid use, etc. So specifically at our institution, we have a very robust referral network. Our pulmonologists and allergists are acutely aware of this condition, and we see a lot of our patients sent from them.
I would agree. At our center, too, it often is a multidisciplinary arrangement, right? Where the patient may see us first or certainly pulmonary first. And we, like you said, you want to try to make sure that you're addressing all the addressables.
And it's a little bit different than I think what we were taught in residency, which is the classic patient, the young female track athlete who after a mile starts to have stridor and dyspnea. A lot of our patients don't fit that textbook case.
So this looked at biofeedback, which was like very interesting to me because when I was looking through the article, I was like, oh man, boy, it's really hard to get people in for biofeedback where I'm at versus the respiratory retraining or respiratory control therapeutic approach that often our colleagues in speech-language pathology will lead. Are you able to share a little bit of the differences or similarities between the two?
Sure. So biofeedback, or we call it specifically here video biofeedback, entails going through the regular laryngeal anatomy with the patient first. So sort of explaining in detail what they're actually looking at as they see the screen live in front of them during their exam. And then subsequently going through some very basic breathing exercises. So for this study specifically, and I think a well-accepted technique for some basic video biofeedback would be to have them breathe in through their nose for 3 seconds and exhale through pursed lips for 5 seconds. And very, very straightforward, very easily taught technique that can be done immediately following the examination. Whereas respiratory retraining, I'm sure our speech pathology colleagues could give a better description, but they go through a variety of different techniques sort of tailored to each individual patient. Again, sort of looking into triggers and a variety of different breathing techniques that can be utilized to help with their symptoms.
And forgive me if you said this, Will, but the patient, while that exam is occurring and while we're looking at their anatomy, so is the patient. So we are pointing out on the screen in front of them what their vocal folds look like as they abduct and as they adduct, so they get that visual feedback while they are performing the breathing maneuvers.
That's great. Not every center is going to have an easy setup to like turn them to see the monitor, whereas some may have a double monitor, right, where you can turn on and see the exam live. So that's a really cool technique and therapeutic approach for the biofeedback. How was the study designed? Can you just walk us through some of the nuts and bolts of how you put it together, and then we'll find out what you found?
So this was a pilot randomized controlled trial, which means it was designed based on feasibility rather than power calculations, since there were no other studies assessing these interventions previously, at least head to head. So we identified about 100 patients who had concern for paradoxical vocal fold motion or inducible laryngeal obstruction who were seen in our clinic, and ultimately randomized 54 of them, so 27 to each group. These patients were recruited based on having an abnormal dyspnea index score of greater than 11, as well as just patient-reported intermittent shortness of breath. The participants in the study were actually included regardless of whether adduction was seen during laryngoscopy. We can talk a little bit more about that further on. But point being, we wanted to recruit a group of patients that would sort of be generally otherwise referred for speech pathology for randomization in this particular trial. So ultimately, we looked at a number of patient-reported outcome measures, focusing on the dyspnea index as our primary outcome. And we did that at baseline, 1 month, and 3 months after completion of their treatment. And again, the treatment was either video biofeedback done at their initial visit, or 2 sessions of respiratory retraining therapy, which were done as outpatient with our speech pathologists. And then ultimately, again, our primary outcome is looking at the difference in the dyspnea index score between 1 month and baseline for these patients. Ultimately, again, we were comparing both within treatment groups and then between the treatment groups in terms of the change in dyspnea index at 1 month.
And did you have any trouble recruiting patients, or people were pretty on board with both approaches, or any insight to share with that?
Yeah, that was certainly the biggest hurdle in executing this project. So it first of all required participants to do a number of patient-reported outcome measures and agree to go through the informed consent process, of course, prior to initiating the study. The biofeedback, of course, requires a little bit of extra time with the endoscopy. So sort of walking participants through that and helping them understand what would be required definitely took some effort. Beyond getting patients to agree to participating, it was certainly challenging tracking them down at the 1 month and 3 month post-treatment marks. So these were not people who were coming back into the clinic necessarily for regular follow-up at 1 month. This did require quite a number of phone calls to get them back in the loop and to complete these online surveys. So I'd say there was quite a lot of work that was required in order to actually catch these people at the 1 month and 3 month marks and get meaningful data for this study.
That's wonderful that you pulled it off. You can only imagine trying to track people down. So congrats on that. And what did you find? What are some of your high-level findings and lessons learned?
So again, we ultimately enrolled 27 participants to each treatment group. And we found that 20 participants of those 27 were able to complete both respiratory retraining sessions, and 24 of the participants who underwent biofeedback completed their 1 month follow-up. So ultimately, we found that there was a pretty minimal difference in the 1 month post treatment outcomes between participants in the biofeedback group and the respiratory retraining group. So there was only a difference of about 0.6. And for context, the dyspnea index scale goes from 0 to 40. The change within the biofeedback group was about 3.5, and the change in the respiratory retraining group was about 4.2. So overall, there were, based on our primary outcome of the change in the dyspnea index, pretty modest benefits for both treatment groups, and very notably, a very minimal difference between the two groups. And I will say, for some additional context, we did ask participants how they felt their symptoms had changed through some other metrics, notably the Clinical Global Impressions of Improvement scale. And that's a 1 through 7 Likert scale. While, again, our change in the dyspnea index scores were pretty modest, we did find that 61% of participants in the biofeedback group and 65% of participants in the respiratory retraining group experienced some amount of improvement after their respective interventions. So there wasn't complete alignment in those very objective dyspnea index outcomes. But we did find that overall, both treatment groups did find that their symptoms had improved somewhat.
Is it the case that people need a little more longitudinal sort of therapeutic intervention to achieve their final resting place, if you will, for where their dyspnea is going to fall and their response rate to either approach? Is that kind of the sense of it?
Yeah, no, that certainly may be possible. And the original study that inspired this work, correct me if I'm wrong, Dr. Strober, but it was a 2021 study that looked at the dyspnea index 3 months following biofeedback. And they reported really encouraging results to the end that I was surprised, because I've been taught that laryngeal control therapy is really the gold standard of treatment. And that sort of inspired this from the beginning. I wanted to prove that what our speech language pathologists do is better than that. And I was quite surprised by the outcome. I do think that what we have learned from this is that there are some patients that certainly will benefit more from therapy. And in our post hoc analysis, we noted that patients who have been diagnosed with generalized anxiety disorder actually responded better to intervention with our speech language pathologist. So to your point, Dr. Bryson, maybe having this more longitudinal care and more touch points may be important for certain populations of our patients. And I think more broadly, what this sort of tells me is that we're probably not stratifying patients appropriately and maybe over referring at this point. There are probably populations of patients that need that laryngeal control therapy, respiratory retraining therapy, whatever you'd like to call it. And maybe there are some patients that don't need that.
Yeah, maybe the power of actually seeing it, like in the biofeedback group, and then you do a maneuver and you're like, yeah, there it is. Like they get instant feedback and then they're able to carry it over without, like you said, all the touch points or less touch points.
No, I think that was exactly what I was thinking, that talking about the comorbidities is very important, and those people might do better with increased longitudinal follow-up with the speech pathologists. That being said, I will say that our 3-month post-treatment outcomes in terms of the response rate were still quite comparable. So it was surprising that there was some potentially durable responses for both groups, even with that just one single biofeedback session.
What are next steps for you? I guess as a team, do you think that you'll have some longer term data to share? Because it really does. It's nice to have some different options for people, right?
Absolutely. I think for patients for whom cost and copays are an issue, or adherence to therapy is an issue, whether they don't have access to telehealth or they're unable to travel, it is nice to have another option. And I think bigger steps for our group is really understanding this condition better than we do right now. I think right now we base a lot of our referrals off of clinical history because many patients aren't having an episode in clinic. And some of our other work has looked at the degree of adduction upon exam is challenging for people to agree upon what truly constitutes PVFM or ILO in the first place. So this sort of nebulous diagnosis that we are coming upon, I'd love to understand better so that we can send appropriate referrals to our speech language pathologists. And so that when patients are paying that copay, I can confidently say, I think you're going to get better.
Well, as we wrap up our podcast, are there any key take-home messages that you want to share with the listener about the identification and treatment of inducible laryngeal obstruction?
Absolutely. I hope that this study spurs more research into understanding this condition better. What I don't want people to take away is that laryngeal control therapy or that respiratory retraining therapy doesn't work for this condition, because I do believe it works and I have seen it work. I do think that we need to be thoughtful about who we are referring to our speech language pathology colleagues rather than have a knee-jerk reaction of, oh, this patient has some inhalational dyspnea and I don't see anything on exam. Let's send to SLP. Hopefully they can fix things. I think we can do better than that.
I really applaud your group and applaud this research. It's important. And for those of us that live in this space, you're right. It's hard. The diagnostic criteria are not completely clear-cut, and sometimes the patient's descriptions do not fit neatly into the box with this. I feel like sometimes there is a tendency to refer and see how people respond, and was that a good use of the referral? I don't know. I think studies like this are going to be important as we try to be a little more refined about how we diagnose and treat this.
Totally agree. And I think it's great to have multiple tools in our arsenal rather than just saying, refer to SLP, see what happens, and potentially never hear back from that patient again, rather than being a little bit more thoughtful in treatment selection.
I really want to thank you both for coming on the podcast today. And I'd encourage our listeners to check out this article. This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.